Good afternoon, everyone, and thank you for joining us today for the webinar on ensuring your meaningful use funding and avoid the ticking time bomb. Before we begin, I'd like to review a few housekeeping items. All participants are now placed on mute. If you have any questions throughout the webinar, please write it on the left-hand side bar where speakers will address the questions once the webinar is finished. Without further ado, I'm going to pass it over to High Point Solutions Senior Vice President of Healthcare, Jim Slabowski. Jim?
Thank you, Jenna, and good evening, or good afternoon, everyone. This is Jim Slabowski, as Jenna mentioned, with High Point Solutions, and welcome to our webinar focusing on meaningful use and compliance, which is an important factor that's been driven by federal law, the Patient Protection and Affordable Care Act. Today, my associate, Jay Fisher, who's our solution leader for meaningful use, will be facilitating and presenting today on this very, very important topic. Jay, next slide, please. The Healthcare Executive Group is a national network of executives from across the country that come together to continually learn, grow, share, and embrace change for the industry. High Point Solutions has been a proud sponsor of the Healthcare Executive Group and also the current sponsor of today's webinar. This is our third webinar in a series focusing on educating and putting together networking opportunities for payers and providers in the healthcare industry so we can learn and grow from one another moving forward. As I mentioned, the important topic today, ensuring compliance with meaningful use, not only to protect funding from the provider side, but as well as for both the payer and the provider to ensure quality indicators and satisfaction scores are met and honored as we serve both our patients and our members moving forward. So to that end, I'd like to introduce Jay Fisher, who's our solution leader for meaningful use and will lead us through this webinar. Jay.
Well, good afternoon. This is Jay, and thanks for participating. So I think the theme that we'll see as I talk through my comments today are about meaningful use, and as you speak with people across the industry in meaningful use, you get a pretty broad range of opinions. One of the range of opinions is, well, it's almost done with. We've had our providers attest, we've achieved meaningful use, we have our EHR, and we're done. But there's another set of opinions that's more grounded into the facts and reflects a theme that we hear as we talk with our clients across the country for whom we're doing meaningful use compliance and meaningful use support work. And one of the interesting themes is that, well, it's true that a lot of the activity that we had in achieving and getting to meaningful use is already in the rearview mirror. It's based on our physicians doing CPOE and our people in our hospital capturing information and starting to share information electronically. A lot of that activity has been in the past. There's some upcoming new capabilities of electronic health records that providers are going to have to use. There's still a lot of big risks in the future, and we'll talk a bit about what those risks are. And fundamentally, they're risks related to, I already got the money, I've already spent the money, but it's possible that somebody could come and take that money away from me. So what we'll talk about today is how a series of some of our large provider clients have evolved from doing projects around implementing new regulations and then taking those projects and converting it into an ongoing operational management of a federal program that, you know what, probably isn't going to end. Even though the reward phase of meaningful use is on, not only is the penalty phase coming up, but we still have a long tail of time under which CMS auditors can come and take some of our money away that we already got. So, and that's, as Jim mentioned, as we talk about the ticking time bomb within meaningful use, that's really what that's all about. Now, if you're a payer and you're sitting in listening to this conversation, one of the things you might be thinking is, well, why does this matter to me? Why is meaningful use something that I ought to care about? Well, I'm gonna tie that into a couple of other CMS initiatives that are very closely aligned with meaningful use. First of all, CMS has published a goal, and they've not often done this before, but they published a goal that said by the year 2016, by the end of 2016, that at least 85% of all Medicare payments will be tied to quality programs. In other words, we'll be migrating from a strictly fee-for-service program to methods under which Medicare will be reimbursing physicians and hospitals based on quality-adjusted fee-for-service or even under more direct related quality programs. And but again, you might ask, well, why does that? If I'm a payer, why does that matter to me? And even if I'm a provider to some degree, why do I care about that? Well, CMS not only is trying to set goals for what they do in terms of tying Medicare payments to quality programs, they're trying to expand and reach out to the marketplace and have posed a challenge to the entire payer marketplace to say, we think that you should come along with us. You should be trying to tie your programs into where there's a quality component as well. Now, we all know that CMS doesn't have a lot of direct influence over payers, but what they've started to do is they've formed a formal organization they call the Learning in Action Network, and I've got a couple of links on the bottom of the slide here that you can copy into your browser or click on and take a look when you get a copy of this presentation, that can allow you to learn more about the Learning in Action Network and even sign up and participate about it. What the Learning in Action Network is, it's a group funded and sponsored and organized by CMS that primarily brings CMS and payers together. There's some other constituents as well. There's some large employers as purchasers, and there are some providers and there are some direct health care consumers, but it's predominantly oriented as a payer and purchaser organization. And it's all about trying to facilitate joint implementation of new models of payment, which CMS is hoping to drive not only payment but also care delivery built around the achievement of quality measures. And here's where the meaningful use component starts to tie into that. When we think about quality measures in hospitals, when I was younger and doing a lot of my payer and hospital side work, we'd put together repositories of quality information that we'd send off to the government or quality organizations or even some payer organizations, and that information was generally based on claims data and some level of abstract out of our clinical data. Where CMS is moving right now is that quality data is coming directly out of the certified EHR technology programs. And not only is the quality data built to be retroactive, in other words, looking back over X number of months to see whether or not a particular clinical action has been taken place and has improved, but also to be able to measure ongoing transaction by transaction patient-physician activity to measure whether or not that activity is consistent with the goals of the quality program. So it's really trying to drive not only historical retrospective reporting, but also EHR technology reporting for quality. And as payers, as you're starting to look forward into, gee, we might start to increase the level to which we're looking at healthcare outcomes and quality measures, you have an ability as well to tap into that certified EHR technology generated quality data. The data itself is generally the same as what it's been, just an issue of the timeliness and the level of integration with care delivery processes is improving day by day. So if we take a look at that, one of the first thoughts that comes to our mind is when is meaningful use done? Is there a sunset to the program? As soon as we're done getting all of our payments, can we just stop doing meaningful use? So, or do we stop doing meaningful use after we've attested to stage 3? What's the real answer? Well, the answer that's in the regulations so far, the Stage 2 Federal Register, which is one of about 8 separate editions of the Federal Register that has discussed meaningful use, that Stage 2 Federal Register identified meaningful use activities that CMS will be engaged in through the year 2021. Now, there's been either the original law nor the regular body of regulatory content has identified an explicit sunset date. So CMS is leaving themselves open to keep the program running in perpetuity. What are some of the reasons they might do that? Well, if providers are not compliant with meaningful use measures in any year, let's say starting in 2021 forward, actually starting in 2013 forward. If providers are not compliant with meaningful use in any year, then in a subsequent year, they will have their Medicare reimbursements reduced. And the amount of the reduction strictly due to meaningful use can be as much as 5%. So what's the likelihood, as you start thinking about programs going on, what's the likelihood that CMS will actually back off a program that they believe is helping to improve quality and can help CMS to reduce their Medicare payments? I think that it might make an awful lot of sense for them to keep a program like this in place. So now we talk about a ticking time bomb and what are the risks of meaningful use, since many of us have already achieved meaningful use already. What can there possibly be in place for risk? Well, what's the process? Install an EHR. Everybody's done that already. It's hard to find a significant hospital or a large physician group, or even a lot of small and modest physician groups that don't have some level of EHR in place right now. And once you've got the EHR, the achievement of meaningful use, quite frankly, is things that just tend to make a lot of sense in the clinical world. Then, of course, comes the process of not only do we achieve it, but we have to tell CMS, we have to fill out our annual attestation forms for every physician in every hospital and actually attest to meaningful use. During the first several years, you receive money from that, but then here comes the hook. CMS has the ability to audit any individual year's meaningful use attestation for up to 6 years after the attestation has been filed. And in the event of an audit, because CMS is always auditing historical data, they're auditing something that happened in the past. You really don't have a lot of opportunities to remediate shortfalls that they find. So in the event of an audit, the threshold under which you pass or fail the audit is 1. Any single error in your ability to prove that you are compliant with any single component of meaningful use is 100% recoupment of the stimulus payment that you received for that year. So the likelihood of an adverse impact, if you've been audited and you have a flaw, the likelihood of an adverse financial impact is just about 100%. Now the amount of the stimulus that goes into hospitals is 6 or 7 digit number for any single year. Individual physicians are much smaller numbers, but the process of managing documents can be pretty significant. We'll take a look at that in a moment too. And documents is an important part of the conversation, because as we help clients work through the process of mock audits and reviewing their documentation, one of the things that we find when we find an organization or an individual physician who we flag as likely to fail an audit, or when we've seen individual organizations or physicians that have failed an audit, as often as not, it's not an issue that the organization was non-compliant during the year, but that they simply didn't have the documentation that was able to prove that they were compliant, or the documentation wasn't in a state that was clear and compelling to an auditor to provide proof. So let's think about what does that adverse impact look like in the real world. A lot of our clients, for all of us, we pay a lot of attention to the bigger health systems, and I've created a kind of a composite client here that I'll talk about on a few of my slides. And so let's call this a health system that's got a dozen or so hospitals and around 1,000 EPs. In this case, the financial exposure for stimulus payments, so the hospital stimulus payments, is $80 million. It's some fairly serious money, and of this organization, another $6 million in ambulatory stimulus payments. The penalty exposure itself ranges from a couple $100 million to $1 million for non-compliance within a particular year, and it gets bigger year by year, both on the physician side and on the hospital side. And the other interesting theme that we're hearing from our providers is, everybody knows whether or not we're a meaningful user, particularly as a large health system, as a large organization, and we simply aren't willing to tolerate any damage to our reputation as a result of a competitor or anyone being able to say, hey, you have all this technology, you're not able to use it as well as your competitors in the neighborhood who, because they're using their EHR better, maybe are delivering better health care. So the damage to reputation is a non-trivial and important part of the conversation as well. So from there, how have we seen meaningful use evolve to where it stands today? And I would say the bottom line to that is that from a CIO or a chief operational officer, the business problem around meaningful use used to be, what do we have to do to achieve meaningful use? What do we have to do to get our clinicians compliant, to get our technology compliant, to get our other administrative and clinical processes compliant? That's not quite so much the issue anymore. We've probably moved to where that's a much smaller percentage of the problem. But what's become a bigger percentage is still the ongoing process of reporting on meaningful use and making sure that our documentation is good enough that we can retain our meaningful use status from year to year. So if as you start thinking about that, you look back, the first couple of years of what we were doing with meaningful use was all about project-related work, right? So we had project managers in charge of it. We had physician training, and we had some monitoring around that training. We tended to use our data management tool techniques and perspectives were project-related tools like spreadsheets. 2014 came around, CMS rolled out a new set of regulations that required that everyone's EHR be upgraded to be able to meet with the regulations. It created a giant set, maybe not quite the same scale as ICD-10, but maybe not too far off. Created a giant set of new implementations or new EHR upgrades for virtually every client in the marketplace. 2015, quite frankly, CMS, we're in the fourth quarter of the year. CMS still has not finalized what are the detailed requirements that people will have to attest to for 2015 and under what process they will attest. We expect that any day now, but part of what we're seeing is meaningful use is still very much an evolving and changing process. But as we've taken a look at the last couple of years, it's the project managers have kind of started to back off, and they've said, hey, let's turn this over to somebody that has day-to-day operational responsibility. We tend to refer to that individual, whether they're in a clinic or a hospital, as a meaningful use coordinator. In the hospitals, that person's job is primarily documentation and mock audit and audit. In physician groups, we're going to take a look at why it's a much, much bigger data management problem and operational process model, and the data volume and complexity around tracking meaningful use and tracking the simple administration of compliance from meaningful use from year to year is growing quite a bit too. Let's take a look for a minute at that meaningful use coordinator, that role of meaningful use coordinator. This tends to be a person in a clinic or in a hospital that's someone at a probably at a manager level, probably not a director level person. They will tend to have relationships with an awful lot of departments around the hospital, from finance through revenue cycle, through internal and external audit, quality reporting, IT. It's an individual that tends to be kind of a mid-level person within an organization that has just a ton of relationships across a lot of other people where they need information. And quite frankly, in all but the very largest, let's say the organizations that have 1,000 or more physicians, it's not big enough to be a full-time job. It's a very complex job, and it's a job that has some very tight time frames at 2 or 3 times throughout the year. But that meaningful use coordinator often gets pulled in other directions as well, and then has a sudden, heavy overtime burden for 2 or 3 months in or around the end of the year. The volume of data can be pretty significant too. In hospitals, pretty manageable. But even in hospitals, the kind of information that mid-level manager has to really be knowledgeable in, they have to be adept at, they have to have almost pseudo CPA or pseudo attorney knowledge of the regulations, multiple different Federal Register documents, many different FAQs, a lot of supplemental information coming out of CMS. The meaning to use coordinator tends to get involved with audits. Not everybody gets audit in the meaning to use world. It's about about a 5 to 10% of the physicians or 5 to 10% of the hospitals a year get audited. Big enough that you have to pay a lot of attention to it, but small enough that it's easy to get a little bit lax and say, well, most of our people aren't going to be audited. Maybe we don't have to be as diligent, and then get some pretty big hits on some areas that do come across. And when you start looking at the documentation, we had we did a little measurement in one of our smaller clients. It was a clinic with about 60 physicians. And by the time you took a look at a single year's attestation, the documentation that they had to provide, the different data elements they had to measure, information they had to extract from the EHR, from the quality reporting system, from their security risk assessment, there were several thousand things that meaning to use coordinator had to have at their fingertips to be able to support decisions and support potential audits. As we've watched the organization grows, even that meaning to use coordinator is an evolving position, and we tend to see, starting moving from the startup consultant to an internal, the project manager goes away and hands off to an office manager or a person with departmental responsibilities. That person pretty quickly finds out that this is not a small enough job that they can work in. They come up with a meaningful meaning to use coordinator, and one of the things that we've seen almost every client that we have today, the meaning to use coordinator that we're working with in 2015 is not the same person that we worked with in 2013. So the job of standardizing process, standardizing where your data is, standardizing how your data is representative becomes more and more important, particularly as people migrate through this very challenging and risky job. There's also not an awful lot of a support group. So if you have joint commission audit situation, you know that there's a pretty good cadre of consulting people that you can connect up with that have made a career. They've been at it for a long time. They're very knowledgeable. The issue, there's not quite that much of a knowledgeable and capable third-party support group that meaning to use coordinator can draw on in the meaning to use work as well. The regulations we're going to see are incredibly complex. Consulting firms, I have to say that it's easy to come up with an answer in meaning for use. It's a little more challenging to come up with an answer that can be defended and supported against auditors that's not based on verbal content, and that is something that can be part of a permanent long-term documentation strategy. And one of the other things that we see is that the people doing the implementation of meaning for use put in place strategies, they put in place operations that work. They get things done, and they get you to a point where your systems are able to measure and even report on some of the, on the meaningful use regulations. But those strategies and those operations sometimes aren't tested for until an audit happens several years after after things are put into place. And there's also few situations that you can go to outside the Federal Register to say, well, what's the body of evidence that says, how have the last couple hundred physicians have been audited? How does that work? So one of the statements that we find our clients making is we have to become self-reliant in terms of our understanding of regulations and interpretations of regulations. And it's hard. I've got to say that the source of the truth really comes down to the Federal Register. There's really no cliff notes to the Federal Register. It's a dense document that develops it's a whole new skill to learning how to read and interpret those documents in itself, apart from meaning for use. And when you start looking around, you'll find that there are a number of different editions and issues of the Federal Register covering separate topics, overlapping topics in most cases, although not all, and having an awful lot of challenge in terms of reading through those things to find out what the laws really are. If you're one of the things that I realized a while ago. My staff and I've been working together on meaningful use since 2010, and we find it to be a steep learning curve. We find it that every year or a couple times a year as the measures come out, it's a big job to study and absorb and interpret those regulations as they happen. But just imagine picturing yourself as a new meaningful use coordinator coming into the job, and you haven't spent the last 4 or 5 years studying all of those regulations. It's a very steep hill to climb, and maybe even unmanageable. So one of the things that another common thread is that we hear across our clients is we need to be able to take those people that have studied and understood this. We need to be able to keep them on our team. We'd be able to keep them in places where they can continue to provide advice back to meaningful use, even though the meaningful use piece itself isn't necessarily 100% full time. And beyond the issue of achieving meaningful use, let me come up here with a couple of examples of simply how providers will contract with their physicians and what kind of an impact that can have on meaningful use. And a lot of those issues revolve around physicians in transition. So let's say we have a physician that moved from clinic A to clinic B. When they were with clinic A, they actually attested to meaningful use a time or two. So they come in with meaningful use history. They move they move into our clinic, and they get audited, and their audit fails because the audit, we just have a physician that just came to work for us now, but they attested with a different employer 2 years ago, and we no longer have access to that employer's documentation. So when the auditor calls, we have no ability to defend that physician, and the physician fails. When the physician fails, CMS doesn't recoup from the provider. They don't recoup from the physician's current employer. They go after the physician directly. So one of the interesting things that we've got to deal with in our contracting with physicians is to make sure that who indemnifies the physician against what particular activities around meaningful use, and what can we incent our physicians to do in the transition mode to get that documentation in our hands so that we can support them if they should happen to get audited. Another interesting scenario that happens more often than not, well, more often than I'd like to think about anyway, is, again, a physician in transition. Physician comes to work for our clinic. They've attested to meaningful use a couple times before. They work for our clinic, and let's say there's a separate process in addition to attesting to meaningful use that we have to do, which is we have to go into a CMS system called PICOS and register that physician to us. If we should fail to do that, no worries, the physician can still attest. No problem. We can go into the CMS website and attest for that physician. The problem is that when the payment gets made, the payment gets sent back to the physician's prior employer if we didn't make their PICOS registration adjustment. So simply keeping track, the meaningful use coordinator's job, and by the way, the meaningful use coordinator in almost no clinics that we work with is the person responsible for conducting that registration back into PICOS. That tends to be done by someone in the revenue cycle, and to them it may not be all that important, particularly as we start moving into areas where the stimulus payments are becoming less and less as we start to get all of our physicians paid out. We do see a set of emerging best practices around meaningful use. One of those best practices I'm going to talk about a little bit is something we call mock audit. But before you even get to the stage of mock audit, there's a whole series of activities that, as we start analyzing our ongoing operational workflow, how much time do we need to dedicate a person for? Well, we can start thinking about some big groups of activities that meaningful use coordinator needs to do. One of them is tracking those physicians that are coming into our organization and quite frankly going out of our organization to make sure that they're well protected and well defended in their with their new employer relative to meaningful use if they should get audited for a period when they were with us. another awfully big step is reporting, is figuring out which physicians, which hospitals, which organizations are actually ready to attest. What are our shortfalls? Working the shortfalls in a timely enough fashion to be able to react to them. And then for those providers who are ready to attest, actually conducting the attestation, which, by the way, is a one-on-one manual process. Imagine that you've got a clinic of even so few as a couple hundred physicians. The job of attesting for the physicians is somewhat akin to, I guess, filling out a Form 1040, short form. Maybe a long form, depending on how the physician chooses or how you choose to attest that physician's quality measures. And then, of course, there's all the pulling together of the documentation to support that attestation or that tax form. So the amount of time that it takes to attest a single physician is roughly equivalent to the amount of time that it takes to fill out a Form 1040. If you got a couple hundred physicians, that means your meaningful use coordinator is doing a couple hundred 1040s. It's a big job that has to happen in a very narrow time frame, a very narrow window. And simply the monitoring of the regulatory updates and what CMS is doing and reacting to CMS audits is, a job that's kind of a non-trivial job. Here's an interesting point. When physicians receive payments from CMS for meaningful use, the payments come in on a remittance advice. It's mixed in with other claims information, but the payments that come in don't always identify what physician they're for. So the process of taking payments that come in and matching them with physicians that have recently attested and trying to balance that out is a job that the meaningful use coordinator gets tied up in quite a bit, and particularly with the CFO knocking on their shoulders saying, did we get all the money we expected, and what should we be, where should we be going, and trying to follow up on some of the attestations that we filed for which we haven't received payments yet. So that process is a big one as well. But ultimately, so let's assume that you've gotten your physicians attested and you've gotten your payments done. Where do the other best practices, where do the rest of the best practices in the market start to fall out? Well, it's all around the preparing and making sure that we don't get embarrassed in an audit. So as we take a look at what are the ways clinics and hospitals have organized themselves, those that are well prepared and well organized have a clear ready team that's set up. The ready team, starts with a compliance leader who's helping to create what are some of the red flags for audits, what's our documentation around strategy. And by the way, CMS has published about a 5-page pamphlet on what kind of documentation providers should have at their fingertips in the event that they get audited. Sounds good, right? Well, unfortunately, there's a catch. At the bottom of page 2 in that pamphlet, CMS has a caveat that says, well, we can't envision all of the circumstances that might come up with an audit, and these are just some examples. The auditors are entitled to ask for any proof that they believe is necessary to validate that you actually achieve meaningful use, and we can't give you a complete listing of what that documentation might be. What that means, of course, is that the meaningful use coordinator needs to collaborate probably with someone in compliance, probably with someone in internal audit, probably with someone in IT to say what kind of documentation might an auditor ask for, what kind of documentation can we create, and is there a match between what they might ask for and what we can create, and if so, let's find the shortfalls. That finding of shortfalls between your strategy and your capabilities is part of a comprehensive mock audit program. So it's a process of defining what we could create, what we should create, and then what we are currently able to create. And then the next phase in the mock audit program is, and by the way, let's take a look at all of our providers in our hospital, or samples of our providers and all of our hospitals, and let's take a look at the documentation that we have organized and make sure that, number one, we have it. Number two, it actually does support the attestations and the measures that we submitted. It actually ties to that Form 1040 that we submitted. And then make sure that it's organized and easily accessible in a way that any knowledgeable person in our organization can get their hands on that documentation anytime within the next 6 years. So as the meaningful use coordinator gets promoted or moves on to other responsibilities, the person that comes in to backfill behind them needs to be able to get their hands on the content. What we've seen and what we've tended to recommend around mock audits is that, number one, if a large organization has an internal audit group that they can tap on the shoulder to do this, it's probably the very best team to bring in. Now the shortfall, the issue that your internal audit team is going to have is they're going to say, well, we understand how to audit and we understand documentation, but we don't understand meaningful use very well, and it's a big target and it's a moving target and it's an annual target. So part of the strategy around having your ready team is making sure that you've got processes in place by which your internal audit people can be knowledgeable and well educated enough to conduct an effective mock audit. We also see third-party auditors. Some of the big audit firms are incorporating mock audit into their program and a group of consultants. We certainly provide what we believe is the industry-leading mock audit, tool-enabled mock audit process and program as well. The important part is to not rely on your meaningful use coordinator to be the individual auditing the documentation that they should be putting together. The rest of the team is, really all about, if the call comes in, who does it come to? And interestingly, the meaningful use coordinator is not necessarily the person who's going to receive the call. The attestations could be done by the meaningful use coordinator. They could be done by the meaningful use coordinator generally in conjunction with someone in the revenue cycle who may or may not be the person who's around when the audit request comes. And the audit requests tend to come electronically and then followed up within a few days with mail, probably to the CFO. So it's who's going to be our team that's going to be available to respond to the audit, and then what process do we have in the event that we do fail an audit. There's an appeal process, and let's make sure that we understand our rights and are prepared to jump forward with appeal as well. So when you start thinking about the complexity and the risks around audits, I've got a couple of case study slides here that really talk about our hypothetical composite client that says, gee, when we take a look at what CMS was demanding from us, we found that much, so we had to create our own documentation. In this composite, actually, this is a quote from an individual client. Their book of evidence for a single physician averages about 500 pages. Their book of evidence for a hospital averages about 750 pages worth of content that they save off for each year. A big part of that was defining the documentation strategies and defining checklists to make sure, do we have the right, we can look at the book and we can see we got a big fat book, but where's the checklist that says, do we have all the things that we should have? So one of the things that organizations are they're taking a look and seeing, okay, this is probably beyond spreadsheets and 3-ring binders. So let's start off by creating some sort of internal tool. So what's the natural migration path? Well, we're going to from Excel, we're going to go to Access. We're going to create Access databases with some physician data, some hospital data, some SharePoint repositories, and quite often the process of building those ad hoc systems create systems that have fairly high learning curves and are difficult to learn, but still a step above the spreadsheet, the spreadsheet kind of technology. Common statement that we're starting to hear from some of our knowledgeable clients is, we understand the stimulus payments are starting to tail out. We also know that this compliance thing is not going to go away. So we've got to have something in place that's not ad hoc and is not project-related temporary. We need to automate. We need to have full-scale tools that can automate where possible, so we get some staffing efficiencies. We need to be able, if we're going to incorporate our internal audit team, we need to have databases that have regulatory content that can direct the internal audit people to the appropriate element of regulations. that will help them to support a mock audit or particularly an internal mock audit. A couple of things our clients have told us is that they really need to do whatever they can to make sure that their knowledgeable staff stays in place and is very efficient around meaningful use, because they tend to have other jobs as well. So client number one, managing their own tools, really started to get in the way of the job. They have scarce IT resources. They couldn't afford to have those resources spend more than a modest amount of time in the building of tools. Spreadsheets, not so well. SharePoint document repositories work, but lack the checklist to say, do we have the right 500 pages worth of documentation content? Same thing with some access databases or some other database techniques that we've seen. A good start, but long-term internally developed tools are really not sustainable, and quite frankly aren't worth, probably not worth the effort of putting people in to sustain. So what do? Clients are starting to look out as an emerging market, a young market with some maturing tools. They do exist. They're a series of tools that provide pretty good value. There's some broad ranges and perspectives in terms of price and what the functionality can be bit. And the interesting part is if you go out and look for meaningful use compliance software or meaningful use support software, it can be a little tricky to find. What's the Google search that you assert to be able to find software? And of course, you have to start with your EHR vendor. The EHR vendor is going to have some capabilities, but they're going to lack tools that can automate some of those. The 1040 creation and submission. They're going to lack tools that have long-term documentation repository or that show an individual provider's attestation over the last 5 or 6 years now and over the last 10 or 15 years as we start to roll forward and gain more history. They're going to lack financial management information about physicians, that information that physicians in transition had before they came to work with our firm. And if you've got, as a number of our clients are starting to have physicians that spend part of the year with one EHR and then later on in the year with a different EHR, either as we're upgrading or as the physician's transitioning from one to another. Today, there's, at least from what we know of, there's 3 solid tools in the marketplace. Meaningful Use Monitor, a tool that we work with, very closely and support. Another product called SA Ignite has a tool called MU Assistant, very good in the physician and the small group practice marketplace. And a third product very closely tied to the Meditech world called IATRIC. These are all tools that have significant provider compliance bases. They're all tools that help with the attestation process and help with the administrative job of keeping our meaningful use coordinator more efficient and making sure that that they can get their job done in a way that someone else can come up behind them very easily. If I go back to our composite client, what are some of the things that we hear as clients actually incorporate their history, their content into third-party systems? First of all, almost every time a client starts to bring their meaningful use spreadsheet and ad hoc data into a structured tool, one of the first things we hear is gosh, our data is not quite as good or as comprehensive or as well organized as what we thought. So the process of doing this has helped us clean up our data. Because the market and the products are still fairly new, the meaningful use administrative vendors have to be flexible with reporting and defining new functionality as the needs emerge, and they have to be able to handle multi EHR vendors even within a similar even within a fairly monolithic health system. So we know that meaningful use will, as time goes on, meaningful use is not the only CMS compliance program that our clients have to work for. We know that as they work with tools, taking that knowledgeable meaningful use coordinator, rolling them into other jobs, there's ACO, value-based modifiers, PKRS compliance. All of this rolls together under a new program that CMS has defined called MIPS, which is a composite of all of these programs together with an ability to incorporate quality reporting as a part of overall fee-for-service, physician reimbursement. So as we start to look at tools, those tools themselves need to be able to have the ability to evolve across a lot of different compliance programs, many of which will be as complex or nearly as complex as meaning to use, and all of which will have long lead times. So what's the future look like? What do we know today? Well, we don't know for certain what's in the minds of CMS. We know that Congress has created a program that does not have an explicit sunset, and CMS has in their Stage 2 documentation identified that every provider in the country is going to have to attest to meaningful use at least through 2021. And we say at least through 2021 because 2021 is the last date that was referenced in a federal register. So we know that clients will have to attest at least through 2021 and retain that attestation history at least through 2027. We also know that CMS develops the regulations in support of the legislation that was issued in 2010. Those regulations are subject to administrative change. The audit standards, the standards under which CMS currently conducts audits, are regulatory. They're not legislative. They're not an act of Congress. CMS has a fairly high degree of latitude in terms of how they choose to audit, how frequently they choose to audit, and how aggressive they choose to be about assuring that the people who've received funds are actually compliant as programs. One of the common observations that I've been able to make is that the current auditors sometimes take a tough stance, but quite frankly, they do not dig as deeply as what their rights allow, nor as deeply as what some third-party organizations believe they should. The OIG has published an annual review. OIG the Office of Inspector General conducts an annual review of the CMS Meaningful Use program, and the reports that OIG has issued have fairly consistently stated, we don't think CMS is being aggressive enough in making sure that people are compliant with the Meaningful Use program, and that the Congress, the country, is getting their money's worth out of the $30 or $40 billion that they've spent on meaningful use. So as we look forward, if you're a provider, what do? Invest in flexibility, do whatever you can to make sure that you've got internal staff that are managing meaningful use, because the third-party market of knowledgeable people is a fairly, it exists, but it's a fairly thin market. And to the extent that's possible, take the core data that you have for your meaningful use program and make sure that that data is usable and flexible enough to be usable across multiple alternate CMS programs as they emerge. And I think that I'm going to pause. That's kind of the end of the prepared remarks we have. Jim, you have anything you want to chime in on the end, or do we have any questions that we should address?
Thank you, Jay. Yes, we should move to questions at this point. As Jenna mentioned at the start of the webinar, if you do have questions, please go ahead and submit them, and we will address them in our remaining 10 minutes for this webinar. Jay, so two questions came in that I'll combine into one and ask it together, so it's a two-part. What is the benefit of meaningful use to payers? And what can payers do to help their providers with meaningful use compliance? You addressed this at the beginning, but if you could address it again, the two questions: what is the benefit of meaningful use to payers, and what can payers do to help their providers in their network with meaningful use compliance?
Well, the regulations, as they're written, were CMS imposing a set of standards for using electronic health record systems and driving how that use happens. So there's no direct and explicit link between other payers, and certainly not not quite yet. But if you start to think outside the box, what might payers benefit from this? I think that meaningful use is going to be tightly coordinated with the CMS MIPS program and with the CMS program under which they're combining quality reporting into the creation of reimbursement models. And they're going to be explicitly drawing payers into collaborative groups to do that. And I think that as some payers start to get involved in creating those quality-based reimbursement methods that are structured to drive up the quality of care and improve outcomes, I think that there's going to be competitive pressures for all payers to come across and participate in some type of programs that are more quality driven than what they are today. And not only more quality driven, but more driven by quality, the measures of which can be proactively tracked and can be tracked in real time and proactively, so that payers can start to get involved with what's going on today in a provider environment relative to quality management and quality reporting. What can providers do to help, or what can payers do to help the providers? Well, I think that certainly make sure that your provider relations people are well aware of meaningful use. They certainly don't have to be in-depth detail experts, but they certainly ought to be aware of a couple points. Number one, electronic health records will become a primary source for information that could be of value to payers as they emerge into quality programs themselves. And they should start to understand what are some of the capabilities of those EHR technologies and the resulting quality reporting that could come out to be a little bit closer to near time. And start to work with, as you're building your quality-driven capabilities, make sure that you're relying on the technologies, the foundation technologies that CMS is requiring that everybody have anyway, and don't try to drive separate reporting systems, separate registries, separate technology, separate components that will require redundant work on the provider side to be able to support additional reporting for your own quality-driven fee schedules. Make sense?
It does, Jay. Thank you very much. Jay, the final question is regarding your insight into the future. So do you feel, and if so, when, will meaningful use stage 3 be confirmed for implementation?
Well, when will it be confirmed? That's a pretty good, that's a pretty good question. CMS has published a, they published a schedule. Stage 3 will be, sometime in 2017. There will be software, EHR technology will have to be certified to a 2015 standard that has yet to be completely finalized. But I see no reason for CMS to move off of their current path, their current commitment to stage 3. The real question is, when will the stage 3 regulations be finalized? We had a stage 3 proposed rule drafted earlier this year. The period of the period under which CMS has asked for for comments and discussion, that period has closed. And so we could expect CMS to be able to publish that final rule literally any time. And no one, I think, has any insights. I've heard rumors that it was going to be published before Thanksgiving. I heard rumors it was going to be published before Labor Day. I've heard rumors it's going to be published before the second week in October. So as to when we'll know what that stage 3 final content might be, or quite frankly, when the 2015, which will be stage 1 and stage 2, final reporting requirements will be. We're hoping for that any day now as well. So I have to say my crystal ball on those topics is no better than anyone else's, although I tend to be skeptical of each of the rumors that I've heard.
Jay, we're at time. Thank you very much for your insightful and thorough presentation. It's greatly appreciated. On behalf of High Point Solutions, a management consulting and IT services organization that supports healthcare and life sciences. This is Jim Slabowski, the Senior Vice President for the Healthcare Business Unit. Thanks to everyone joining us today, and we look forward and are excited to continue to support and sponsor the Healthcare Executive Group as it moves forward with additional education and collaborative opportunities. I hope everyone has a great day, and thank you very much for joining us.